Well, good morning, folks. It's Eileen Bird here at the 2Life office on a snowy day. If you didn't need a reminder that we live in the Northeast, then take a look outside your window at this particular moment. We are certainly coming down with what my father would have called a doozy of a storm. And so thankfully, we are able to use the power of technology and of course, brilliant minds in the room to bring a program to you today. So again, I'm Eileen Bird with 2Life. Each of you who have joined on will be joined in mute, and we will not have visibility. We will have our panelists, and we've got people on standby already. And so I want to say thank you for signing up for the program, for being part of the Women's Health Conference series. This is going to be the fourth of our six talks in the series that are coming through. And this particular talk is going to be about the impact of breast cancer treatment on our bone health. And I'm sure our bones and joints are on our minds, probably sometimes more prominently than others. And so we're going to learn a lot more about that topic today from a few different angles. And so our presenter will be Dr. Mary Pat Roy, and I'll give you a little more introduction. I want to say also thank you to our sponsors who have been with us through the program, the Department of Health, the New York State Department of Health, the Amona Corporation, Genentech, and Saratoga Hospital. And so I'd at this point like to introduce Mara Ginsberg, the founder and president of 2Life, and she would like to say a few words.
Thank you, Eileen. And it is great to be planning this having this virtually, so we didn't have to brave the snow. Couldn't even walk my dog, let alone drive the car. So thank you again, Dr. Roy, for joining us. It's been some time since we at 2Life, we provide a great many education programs during the year, but it's been a good deal of time since we've had a focus on bone health. And, some people, thinking about breast cancer might wonder why that's in any way relevant. And it's relevant for many reasons. Most of the people on this call are probably women, and they learn about or they hear about, keeping their bones strong, and are you supposed to exercise using your upper body, and what's weight bearing, and what does that mean, and is it important, etc. But that's just important as women to understand our bone health. But as breast cancer survivors, and I'll use myself as an example, I'm not young anymore, but I was young when I was diagnosed. I was 37. And by 39, between the chemotherapy and surgical procedures, I was in menopause. So the bone health issues frequently, maybe the right word isn't accelerate, but the issues can accelerate post-menopause. So for those of us that start that process artificially, if you will, at a young age, at 39, instead of say 59 or maybe even later, then whatever might have happened in our out years happens potentially sooner. So that's potentially unfortunate, but the great news is there are treatments and there are ways to address this. And I'm not going to curse myself by telling you that I've fallen but not yet broken a bone, because that would be a curse. But so I think it's important for us as breast cancer survivors to know how best to take care of ourselves and which of our healthcare providers are in the best position to help us. And when should we have a bone scan, a DEXA scan, or, bone density scan, and when do you have a baseline, and all kinds of things. So today should be really informative. And again, I thank you very much for participating, and I'm going to kick it back to Eileen, and then we'll get started.
Okay, thanks, Mara. And I want to add on that as all the participants are joining on, and if you can hear my voice, then you will be able to navigate down towards the bottom of your screen, and you will see that there is a Q&A box that you can click onto. And in that box, you can type questions for Dr. Roy. Now, the way this morning's going to go is that Dr. Roy has some prepared remarks and some wonderful information to share. She's got terrific slides. And I think there's so much information in that head. So we're going to go through that the presentation part, and then we're going to do a Q&A. And so I'm going to be monitoring the questions throughout her presentation, and then we'll get started and get those questions in front of Dr. Roy and ask them live. And so type your question whenever you think about it, and we will get to those following the presentation. And I'd like to get right to it now. So let me do an introduction and give you a little bit of information about our speaker. Mary Pat Roy is an endocrinologist, and she is affiliated with Albany Stratton Veterans Affairs Medical Center here in Albany. She has over 25 years experience in endocrinology, diabetes, metabolism, and thyroid health. Dr. Roy graduated from Loyola University, Chicago Strict School of Medicine, and completed her residency in internal medicine and a fellowship in endocrinology, diabetes, and metabolism at Bay State Medical Center, Tufts University. Dr. Roy is board certified in internal medicine and endocrinology, diabetes, and metabolism. In addition to Dr. Roy's professional background, she has personal experience with the impact of breast cancer treatment on bones and joints, as she herself is a survivor. And with that, I'd like to welcome Dr. Roy and turn it over to you. Thanks for being with us today.
Thank you so much, Eileen. Let me share my screen here. There we go. Okay, and pull my slides up here. It's coming, hang on. There we go. Okay, good morning, everyone. My name is Mary Pat Roy, and I love bones. I don't know why. I have just fallen in love with bones, and this was even before I got breast cancer. So what we're going to do, okay, is I have quite a few slides, so I'm going to go through them rather quickly, okay, just to bring everyone to the same page, and then we're going to answer some questions. So what we're going to cover today is we are men and women, women and men first, okay? So we're going to do general bone health, the basics of what osteoporosis is, then the breast cancer medications and how they impact the bones, and then what can we do about all this? So we're going to start with bone growth. So what happens, and I actually love this slide just because I think the pictures are great, but there's this phase called the active bone growth. And until about the age of 30, that's when our bones finish growing. So we have active bone growth. Then from about 30 in a woman to age 50, 51, which is the average age of menopause, we have a little bit of loss, but then after that, we have a very rapid loss. So this is the history of our bones. But now let's go deeper. Bones are phenomenally interesting. Look at this great picture. We have a couple different cells I want to tell you about, because you'll see later when I talk about the medications, I want you to know where we're impacting bones. So buried deep in the bones are these cells called osteocytes, and they're the ones that keep our bones healthy. But then the osteocytes talk to the osteoclasts, and then the osteoclasts talk to the osteoblasts. Now, let me simplify it. Here we have our bone. What happens every day, okay, is we have these osteoclasts that come in and dig out the bone. The way I think of it, because it's my age group, and I'm going to age myself here, and not all of you know this, but some of you do, is Pac-Man, the very first video game that came out. These osteoclasts chew out what we call a resorption pit. Okay, so there's damaged bone there. These osteoclasts come and vacuum cleaner it out. Then these new cells called the osteoblasts, B for build, okay, come in and lay down new bone, and everything looks great. Now let's talk about menopause. So what happens is, like I said, when you have normal bone turnover, you dig out a resorption pit and you fill it back in. Well, what happens when we lose our estrogen is these osteoclast guys become a lot more active and dig out more resorption pits. And the osteoblasts are not nearly as efficient, and they don't fully fill in the holes. So what that results in, here's our beautiful normal bone. Here's osteopenia, where we start losing bone, and outright osteoporosis, where those osteoclasts chew out a lot more than the osteoblasts build up. So this is what happens to everyone's bones, especially in women at the time of menopause, but you'll see in a minute, oh no, not yet, coming to a slide later, where it also happens in men. So how do we measure bone density? Just like Mara referred to, there's a test called a DEXA, D-X-A. Some people call it a bone mineral density test. It's a very, very simple X-ray. There is actually less radiation in a DEXA scan than getting on the plane in Albany and flying to LA. All right, this is less radiation than that. And what it does, it's going to measure the density, how much calcium, how much mineral is in our bones, in the spine, the forearms if we need it, and our hips. It's considered the gold standard. Okay, so here's the slide I thought was next. And what you can see is that men at the age of 30 have a higher peak bone mass than women. And it's easy. The simple reason for that is their bones are bigger. They're not a different kind of bone. They're just like our bones, only they're bigger around and bigger tall. So that's why peak bone mass in men is significantly higher than women. And again, to remind you, from 30 to about 50, we lose a little. Then we have that very rapid loss of bone. Menopause, no matter what time, you're going to have this very 5 to 10 year loss, and then it smooths back out. Men, on the other hand, have a slow, gradual loss with time, because with aging, men's testosterone levels go down. Okay, we start in the general population now, I'm not talking breast cancer, we start worrying about men's bones at about the age of 70, whereas women, okay, we're going to worry at the time of menopause. All right, so when you get your bone density back, okay, I want all of you to know what the important number is. Okay, so there's going to be this thing called a T-score. So let me describe what a T-score is so you guys all understand it. Okay, so here on the red, you see it right there? That's the slide that we just saw, okay? That the gradual loss over time. Okay, here's my person here. Here's the star, okay? So I plot their bone density. It's right there. Here is the peak bone mass at the age of 30. So what a T-score is, it's me or my person compared to that ideal 30-year-old. We match sex. So women, it's going to be a 30-year-old woman. In men, it's going to be a 30-year-old man. We're going to also match ethnicity. Okay. African Americans, actually bones are a little big rounder. Okay. So I will be compared to my T-score is me compared to a 30-year-old white woman. Okay. So you want to know the T-score because that's what all of our therapy decisions are based on. Okay. So T-score. WHO, which stands for World Health Organization, has come up with these definitions. Now, to take a little sidetrack here, because I find it fascinating, okay? When the World Health Organization actually came up with this thing called the T-score, okay, they did not mean it to be a diagnosis. They were just doing a definition and a description, okay? And this was back in 1994. But because it has stuck to, and all the good data shows that these T-scores, this bone density number, can help us decide who's going to fracture, who's not, we have kept them. So normal bone density is if your T-score is better than a minus 1.0. Osteoporosis is when your T-score is 2.5 or lower. And then this part in the middle is called osteopenia. It's -1 to -2.5. So when you know your T-score, you could say, okay, that's normal. That's osteopenia, or yikes, that's osteoporosis. And it will help us decide where we need to go with you. So here's your bone density. Run you through it quickly. What you're going to do is you'll see what we call a poor man's X-ray. Again, there's not enough radiation here for me to, say you have arthritis, for me to, make a bone diagnosis, but you certainly know you're looking at the spine here. There's the last rib, And you can just start seeing the beginning of the pelvis, of the hips. So if you look over here, here's my person, okay? Here they rather than a star, they use a circle. Here is my person. Her total T-score is a plus 0.4. She's in the green. She's in the normal range. These 3 bars show what we expect her to be. So compared to the 30-year-old, which is right here, she's a little bit less, but compared to the average for her age, she's a little bit better. On the other hand, let's go over here and look at the hip. We're going to look at 2 things in the hip. One is going to be this big square that's called the total hip. And then the other one is this rectangle right there, and that's the femoral neck. The reason in the hip we look at 2 different sites and not just the total hip is because this bone here in the femoral neck is where most of the fractures occur. And this femoral neck, the bone is slightly different than the bone down here. So we want to look at both the total and the femoral neck. And if we look here, this particular person in her neck, not this neck, the femoral neck, okay? So if you see neck, I'm not talking neck up here, you could see her T-score is a minus 4.0. Her total hip T-score is a minus 3.6, puts her down here. If I compare it to the 30-year-old, you can see she's that much lower, fits into the category of osteoporosis. Okay, so when you have your bone density, you don't want to say, how am I compared to a woman my age? You want to say, what's my T-score? How am I compared to that 30-year-old? Because that's where the data comes from. Okay, so a couple things. You know what? I really don't care what your bone density is. Okay, it's not the most important issue. What's important is the fracture, okay? We need to prevent the fracture. Bone density helps us, but fracture is more about bone strength. So let's look at it. Here's bone mass. Here's my bone density we just talked about, and the one thing we can measure and the thing that we base our therapy on. Bone mass depends on hormones, depends on nutrition, depends on exercise and lifestyle, including childhood. So total aside here, I'm going to do a little bit of a commercial. Those of you with children, those of you with grandchildren, those of you with great-grandchildren. Nutrition, exercise, and lifestyle. Please make sure kids are still getting calcium and they're playing and they're not all on their little handheld devices. So all those come together to make bone mass. But then in addition to our bone density, okay, what's the shape and architecture of those bones? What's the material? I come from a family of construction people and engineers. So what's the material property? How good? What's the quality of that bone? Those all lead to this thing called bone strength. So bone strength is made up of bone density, architecture, and quality. So we got bone strength, but bone strength with a fall. Bone strength, how your reflexes. Can you not fall? How much, I got quite a bit, how much soft padding do you have on the hip? All of those are what lead to fracture. And fracture is what I care about. And fracture is what you guys need to care about. Okay, so what's the big deal about fractures? Well, I'm going to give you a little Medicare data. Now, granted, that's 65 and above, okay? But we don't have a whole lot of premenopausal data, okay? So nearly 1 in 5 people on Medicare, because they can follow this, okay? Nearly 1 in 5 people die within 12 months of their new fracture, especially if that's a hip fracture. Okay, next, about 15% of those people who have a fracture are going to have another fracture within that next year. And lastly, but very important, is the total cost of fractures across the United States. Okay, and this is back in 2018. And as you can see, we're talking medical costs, we're talking nursing home, we're talking loss of work wages, you have to have a home visiting nurse come in. We're talking $57 billion. So let's put it in perspective, okay? I fit in this category, okay? This breast cancer category is very important to me, okay? But actually, okay, about 1.5 million women are going to fracture in a year compared to 182,000 of us getting breast cancer, okay? It's huge. It's more than the combined heart attacks, strokes, and breast cancer. Men, on the other hand, only have about 600,000 fractures a year. Okay, about the same as heart attack, but certainly a lot more than prostate cancer. Okay, so we worry about breast cancer, we worry about prostate cancer. I'm going to say, let's worry about fracture. Okay, you see where I'm coming from? We need to prevent the fracture. All right, so change gears. How am I doing time-wise? Okay so far. So bone loss associated with cancer therapy. These are old statistics from a great study called the Women's Health Initiative. And the observational arm, meaning they were just following these women just to see what was going on, they found that the women with breast cancer actually had a 15% higher fracture rate than the women without breast cancer. And what we know is that the average yearly BMD, bone mineral density loss in menopause is about 1 to 2% per year. Okay, women on AIs, aromatase inhibitor therapy, are going to lose 2 to 4% per year. And then within 12 months of chemotherapy, if you have the premenopausal breast cancer, you're going to lose 4 to 7%. So here's in pictures. Okay, normal menopause, you're going to lose up to 2% per year. Aromatase inhibitor, we're going to lose 3 to 4%. Tamoxifen, you're actually going to get about 1% back. But chemotherapy-induced OF, ovarian failure. So if the chemotherapy puts you into menopause, you're going to lose up to 8%. And the GnRH, which is, if you will, the chemical menopause we use in breast cancer, is going to be even higher. So that's where, here's the general population, this is where breast cancer people are impacted. So let's start a little bit with chemotherapy. Chemotherapy can hurt the bones in several ways. One of them is a direct toxin onto the ovaries. Okay, it wipes out ovarian tissue and causes premature menopause. But a lot of people forget, and that's in the premenopausal woman, but a lot of people forget that chemotherapy is a direct toxin to the bone as well. So this is if you have postmenopausal breast cancer chemotherapy, you're already done, you're already menopausal, but I'm going to tell you the chemicals themselves are harmful to the bone. The other adjuvant therapies are all directed against decreasing the estrogen action at the level of the breast tissue. So what we want to do with our adjuvant therapy is inhibit the impact of estrogen on the breast. So in our premenopausal women, we're going to block the estrogen receptors with tamoxifen. We're going to suppress our ovarian function. In other words, we're going to decrease the estrogen in the body by either surgery or ovarian suppression with the GnRH, the gonadotropin releasing hormones. In our postmenopausal women, we're going to block the estrogen receptors, tamoxifen, or there's another one we can use called raloxifene, and we're going to inhibit the aromatase-induced synthesis of estrogen, blah, 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 blah. So it's really interesting. So let me tell you, and women on an AI, most women know this, but I want everybody to know this, okay? Here we're saying we're going to decrease the estrogen in a menopausal woman. Well, if the ovaries don't work, why does a woman have estrogen? So let's talk about the sources of estrogen in menopause, because I pull a menopausal woman off the street and measure her estrogen level. She's getting very low levels, but she's going to have estrogen in her. So early on in menopause, estrogen still comes from the failing ovary. It's not like a light switch where you 1 minute you're making estrogen and the next you're not. The ovary slowly fails and the estrogen level is going to go down. But more importantly, in the muscle and adipose, fat tissue, okay, there's this thing called an aromatase enzyme. It's going to convert androstenedione to estrone, which is a weak estrogen, and testosterone to estradiol. So I got a picture coming up of that, so hold on for a sec. Breast cells also have this aromatase enzyme. Okay, so actually in breast tissue, there may be a 6 to 10-fold higher estrogen level in the breast than in the blood that we're measuring. So here we go. Here's the brain. Here's that wonderful pituitary gland right smack dab center of your brain. It makes a hormone called LH, luteinizing hormone, which goes to the ovary when the ovary is working. So we're talking premenopausal here, makes lots of estrogen, but the ovary also makes testosterone. Okay. Another hormone that comes from the pituitary is called ACTH. That goes to the adrenal glands, and the adrenal gland is a small, honest to goodness, shaped like that gland right above our kidneys. Okay, and that makes a very weak male hormone called DHEA. DHEA, estradiol, and testosterone all go into the breast tissue. So if you have the DHEA, it directly becomes testosterone, and then with that aromatase enzyme, testosterone is changed to estradiol. DHEA also can be directly changed into estrone, which is a weaker estrogen, but estrone can be changed into estradiol. So even if your ovaries are taken out, you still have an adrenal gland adrenal glands, there's two of them, that's going to make DHEA, which automatically makes testosterone, and testosterone is very easily changed into estrogen. So it's this estradiol at the level of the breast that we're trying to block. But it can have, the way I describe it to my women who go on aromatase inhibitors, okay, so we're blocking that estrogen, is I'm going to take a really low level of estrogen in the blood and make it zero. Okay, so not only at the level of the breast, but in the blood. And that's why, as you guys know, and this is not a talk about side effects of medication, but one of the number one side effects of aromatase inhibitor is hot flashes. Because I'm taking this much estrogen and making it this much. Okay, but now let's go back to the premenopausal woman and talk about the GnRH, the gonadotropin releasing hormones. They have an indirect effect on the ovary such that we stop FSH, so there's no more stimulation to the ovary. So if there's no stimulation to the ovary, estrogen levels are going to decrease, as are the eggs in the follicles. GnRH also has a direct effect on the ovary, basically wiping out the follicles that contain the eggs. So that's why GnRH, gonadotropin releasing hormones, cause menopause, and also in quite a few women, depending on how close you are to menopause, may also cause infertility. Okay, so now let's talk about the aromatase inhibitors. Here's the testosterone, here's the androstenedione. Testosterone is directly, remember, changed into estradiol, and the reason there's an O there is Nature Reviews is a journal that actually comes out of England. Okay, so that's how they spell estrogen over there. Okay, so the aromatase enzyme, an aromatase inhibitor, is going to block that, so testosterone cannot make estrogen, and the estrogen levels are going to go down. On the other hand, in the menopausal woman and the premenopausal woman, testosterone is changed into estrogen. Estrogen is taken inside of the cell to the ER, that's estrogen receptor. Tamoxifen blocks the estrogen from attaching to the receptor. Because if the estrogen, these little blue balls, attaches to the receptor, it causes proliferation, which means it increases the growth of cells. And if it's a cancer cell, estrogen is going to cause that cancer cell to grow. So that's how tamoxifen blocks the estrogen receptor. Now, here's a little bit of data looking at aromatase inhibitor and bone density. We already saw the slide, but this was an interesting study, I thought, because it took two groups of women. Both groups have breast cancer. One group was put on aromatase inhibitor, the other group was not. And the aromatase inhibitor is the dark line group, and the no aromatase inhibitor is the dotted line. Okay, what you can see, which is interesting, is both groups within the first year, diagnosis to year one, have a significant loss in, here's the bone density at the spine, the femoral neck, and the total hip. Remember the three I told you we're watching. And you can see, though, in a woman not put on a aromatase inhibitor, you're going to have that initial loss, but then it kind of evens out and is not such a big deal. Whereas a woman on an aromatase inhibitor is going to continue to lose over 3 years. That's as long as this study was. Okay, and we all know you're on aromatase inhibitors for more than 3 years. So let's talk osteoporosis therapy. So I'm going back to the general population right now. Okay, so who in the general population needs to be put on a drug? Not, notice I say to decrease fracture risk, not to do anything with the bone density, decrease the risk of fracture. That's what it's all about. Okay, so people who are in that osteopenia range, T-score -1 to -2.5, if they've already had a fracture, if they've had a fracture of the hip or fracture of the spine. Now, I'm not talking a car accident and you broke your hip. I'm talking like Mara, thank goodness she did not fracture when she fell, but let's say when you fell, she broke her hip. You know what? I don't care what her bone density is. She's had a fracture. She's going to fracture again. We're going to treat her. Next is if you have osteoporosis. So if your T-score, again, back to the bone density, is a -2.5 or lower, you should think about therapy. And then the last one that I'm not going to go through because of time, because this talk should actually be a 2-day symposium, but I'll pull back on it. There's a calculation we can do called FRAX. And what it is, it takes into account the T-score, a person in the osteopenia range, and it adds in risk factors. Are they a smoker? Okay. Has their mother or father ever fractured? Are they a drinker? Are they on prednisone? Okay. What's your age? It takes all of that and it gives me a probability of a fracture. And we do this both for men and women. But now let's talk about breast cancer survivors. Okay, who should receive an osteoporosis medication? Well, guess what? We're general population. Okay, so any of those 3 criteria I just talked about are gonna be the same for us, regardless of whether we're actively in the middle of doing our breast cancer treatment or we're years past our breast cancer treatment. Okay, but a couple special ones for the breast cancer people. Women with breast cancer who have other quote unquote high risk for fracture findings. So the data shows that, and most experts agree, that if you're on an aromatase inhibitor, okay, and your T-score hits a -2.0, so still osteopenia, not osteoporosis, because we know from that one slide that you're going to continue to lose bone density, okay, that's when we're suggesting women start an osteoporosis medication in the osteopenia range with aromatase inhibitor therapy. Okay, on the other hand, if you have osteopenia and your medication has caused you to go into premature ovarian failure, okay, if we've made you menopausal, whether it's because of surgery or because of chemotherapy or because of GnRH, okay, and you're anywhere in the osteopenia range. So here, let's look at pre and peri. Peri means right around the time of menopause. Okay, so this is a woman, 45 to 55, may go 8 months and then have a period and, that type of thing. So they're not totally done. What we know is if your menses, if your periods continue, okay, that means you have enough estrogen on board and no further workup is needed. On the other hand, if your periods stop for more than a year, regardless of your age, bone density should be done. If you're greater than that -2.0, we're just going to watch you, okay? Me doing bones for a living, I would watch you yearly. Some people, on the other hand, though, and a lot of the insurance companies say, oh, bone density only needs to be done every 2 years. Okay, well, I'm going to tell you, you're going to lose, 2 to 4% every year. I want a yearly bone density. Because if you're -1.9, trust me, you're going to be a -2.0 pretty quickly. On the other hand, if your T-score is less than -2.0, we want to check your vitamin D level. We want to check your parathyroid, your calcium. You need some blood work. And then we're going to think about treating you because now you're at high risk for failure, for fracture. Okay, whizzing through. So let's do the basics of optimizing bone health. And this is for everybody. Everybody, I don't care what your medical diagnosis is, okay? Is this you? All right, caffeine is not good for the bones. Salt, you do too much salt, you're gonna try to pee it out. Calcium follows sodium, you're gonna lose calcium in the urine, okay? Smoking, a direct toxin on the bone. Too much alcohol, okay? Lots of reasons that's not good for bones. Soda, and are you a couch potato? Okay, if any of this is you, you gotta change it. Next, again, we're doing basics here, fall-proof your house, okay? Because falls beget fractures. Remove the clutter, remove the cords, remove the throw rugs, okay? Keep the halls, stairs, and entryways, have good lighting, okay? I don't care how old you are, have a night light, okay? Or if you get up to go to the bathroom, you turn the light on, okay? Have grab bars, have nonstick rubber mats in the shower or the bathtub, okay? Have the mat you're gonna have in front of your sink in your bathroom and the sink in the kitchen, have the kind with the rubber on the bottom, or get one of those things that make it non-slip. Watch out for pets, okay? I have a cat. She hasn't walked across the screen yet, but I wouldn't be surprised if she did. And especially when I go down the stairs, she oftentimes will go in and out of my legs. So please be careful of your pets. I made this slide before I knew there was a storm coming. So I would have said winter is here if I knew what it was going to look like out my door today, okay? But really important, this is where, if you need to know where I want you to spend money, I need you having good boots, okay? I don't care, they can be stylish if you want them to, but I don't really want them stylish. I want good soles on the bottom that aren't going to slip. Or you can get these things called yak tracks, which are, you pull them on, they're cleats that you pull on over the top of your boots to help you not slip on ice. Okay, you need sand, cat litter, or salt. Don't have it outside on the porch, because you open the door, step out onto the porch, hit that ice, go down and break your hip. Find a nice little box or one of those tins and have it inside the door so you shake it before you step out onto the porch to go shovel. Be careful of black ice. Use handrails. Okay, ask for help. You know, I play that card all the time. I'm old and I have breast cancer. Can you come and, I say this to my nephews, can you come and shovel my walk? And don't go out in the bad weather unless you really, really, really need to. All right, calcium and vitamin D. The recommended requirements in a premenopausal woman and men less than 70 is 1,000 milligrams a day. In menopausal women and men over 70, we need 1,200 milligrams a day. Always choose calcium in the diet first and then supplement if you need to supplement. That's what supplement means. I don't want all your calcium coming from chews or Tums or calcium carbonate pills. I want it coming from the diet. So you can find these lists anywhere, but just a couple things I want to point out to you, okay? Everyone thinks ice cream is, it's cream. Well, no, look it only has, one cup only has 70 to 90 milligrams of calcium, whereas frozen yogurt has 205. Plain yogurt is a wonderful source. Milk in a cup has 300. Get those kids drinking milk, please. All your different cheeses. Here, if you are a sardine person, you are golden. Look at you. Every time you have sardines, okay, you're getting 325 milligrams of calcium. Okay, most people don't realize there's 50 milligrams of calcium in an orange, and figs are actually a good source of calcium. So if you just want to think simple, okay, high categories are your dairy foods, your sardines, and all these things fortified. So for instance, tofu. Tofu is fortified, meaning calcium is added to tofu. Okay, a lot of cereals have calcium in it. They're fortified. Cereals don't automatically come with calcium. Okay, then almonds, beans, your canned salmon, your greens. And then there's a couple that are still good. You want a snack? Go have some almonds. Okay, you're going to get yourself a good protein and you're going to get yourself some calcium. So real quick, looking at the back of the nutrition, what you want to do when you're looking at a label, okay, to find out how much calcium is in it. The first thing you do is you always want to look at the serving size. So if I were to make this macaroni and cheese, it's going to be for 2 people, okay? So if I eat the whole thing, I'm going to double my numbers here. But if I eat half, it's going to tell me that down here, it says I'm going to get 20% calcium. Okay, oh, what's 20% calcium? This is based on the 1,000 milligrams. So the only thing you can do, calcium is the only thing on the label that you say, okay, 20%, I'm going to add a 0. That tells me there's 200 milligrams in my portion of this macaroni and cheese. If it says 5%, that means 50 milligrams. Okay, so with your calcium, just put an extra 0 behind it, and it'll tell you in whatever you're eating how much calcium. So vitamin D. Vitamin D is essential because we can't absorb calcium without vitamin D. The recommended daily allowance varies. It depends on who you read. It may be 600 and maybe as high as 2,000. Okay, so our sources of vitamin D are food, sunshine, and supplements. Well, it's really, really, really hard to get enough vitamin D from food. Okay, our fatty fishes, again, there's our sardines, will have a significant amount. There's 44 units in an egg yolk, okay? But dairy, the thing you need to remember about dairy, milk from the cow, which then goes on to make cheese, has 0 vitamin D. Milk is fortified with vitamin D, meaning if you're drinking your own milk, you're drinking it from the local farm, okay, it has no D in it. The stuff you buy in the grocery store, 8 ounces has about 100 units of vitamin D. And if I'm telling you need a minimum of 1,000, okay, it's going to be really hard to get it in food. So then that brings us to the sunshine. Okay, quick thing on sun here. The sun releases several types of radiation, but the two we care about are UVA and UVB. Okay, but only the UVB is the one that touches our skin and makes vitamin D. Okay, so problem is, if you're like me, fair as fair can be, I hardly go outside without sunscreen. An SPF of 8 or higher totally blocks the sunshine from making vitamin D. And we live in the Albany area, okay? And I'm not making this up. From October 1st until the end of April, okay, the sun is not in the right position, okay? August, I'm here, the sun is here, UVA, UVB rays come down. Okay, right now, I'm here, the sun is over here. UVA rays can come down and still give me a sunburn if I go for a walk outside or go skiing, but UVB rays are going to bounce off the ozone. So from October 1st to April 1st, if you live up here where we live, you're making 0 vitamin D in your skin. So that's when you need to supplement it. And you need to supplement it between 1,000 and 2,000. I usually tell my people, let's start with 1,000 and see where you are. Okay, osteoporosis medications. They're divided into 2 categories. Okay, the anabolic, which means growing bone, the anti-resorptive, which means we're going to stop the bones from going down. So anabolic, it works on those osteoblasts, those cells that build the bone. Anti-resorptives get rid of the osteoclasts that break down the bone. Okay, so just wanted to put that here. But if we talk about the bone anabolic agents, okay, we very, very, very rarely use them in any cancer population, including breast cancer. Because what happens is we will not use these bone growth factors in anyone who has had external beam radiation therapy, or in the case of prostate, implant seed radiation. Okay, because the theory is if that external beam radiation hurt the ribs, touch the ribs right below the breast there, that bone may be harmed. And if I give a bone growth agent to an abnormal bone, in theory, it can cause a cancer in the bone. And the other thing we do is, again, when it comes to metastatic disease, we don't want to give a bone growth factor to any abnormal bone. So then we have our SERMs, our selective estrogen receptor modulators. The one that everyone in the breast cancer world knows about is tamoxifen, but there's one in the bone world called relaxafene or Avista. So tamoxifen is FDA approved for the treatment and prevention of breast cancer. But because it's such an old drug and such a good drug, though, it doesn't tell us much about what does it do to decrease fracture risk. You saw the slide that it's going to keep bone density maybe 1% better, but you're certainly not going to lose bone when you're on tamoxifen. But I don't know about fracture. Avista, excuse me, Avista, on the other hand, is FDA approved for the treatment and prevention of osteoporosis. But there was a great trial called the STAR trial, which suggested that relaxafene is not quite as good, but almost as good as tamoxifen in decreasing of blocking the estrogen receptor and decreasing breast cancer. So in some of my women who have osteopenia and need to be on tamoxifen, I work with their oncologist and we actually put them on relaxafene instead. Okay, the bisphosphonates are the category everybody knows about. They come both oral and they come intravenous. Okay, we know it can increase bone density. We absolutely know it decreases fracture risk. Okay, there's good studies that show it's going to decrease the bone density loss associated with our aromatase inhibitors. Okay, and there's mixed data. Some data says that the bisphosphonates decrease the likelihood of bone metastases. Other data is not quite so positive, but there's no negative data on it. Okay, and the theory behind that would be, so down here you have your blood vessel, and let's say you have some tumor cells in the blood vessel, then they go into the bone, okay, and these osteoclasts are going to lead to the bone metastases. Well, using these bisphosphonates, what's going to happen is we're going to stop the invasion out of the blood vessel into the bone, and we're going to decrease the osteoclast from working. So in theory, it decreases bone metastases. Okay, so the good, the bads, and the uglies with bisphosphonates. We have lots of long-term data. These have been out since the 1990s. A lot of them are now generic, so they're less expensive. Potential side effects, though. They're acting directly on the bone, you can have bone pain. Okay, the oral ones, you may get an upset stomach, and these can cause some joint pains. But the two that the people always question and worry about are the ones that are called osteonecrosis of the jaw, ONJ, or atypical femur fracture, AFF. So, gross picture, and I know it's early in the morning, but here's a tooth, here's a tooth. Here is some non-healing bone after the tooth was pulled. That's osteonecrosis of the jaw. Atypical femur fracture is a fracture down here in the femur, not up here in the femoral neck like we were talking about, literally in the shaft of the femur, that is due to the fact that so much of these bisphosphonates go into the bone. It makes it stronger, 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 stronger. Then we have the hit the top, and then it becomes brittle. So that's back to that slide ago that said, what are the material properties of the bone? If we put too much bisphosphonate into the bones, we may actually increase fragility. But let's put it in perspective. The chances of someone having osteocrosis of the jaw, an osteoporosis patient, is 0.7 per 100,000 per year. The chance of you having a fracture is well above that. And look at hip fracture. Okay, you're more likely to have an anaphylactic reaction to penicillin. You're more likely to die of a car accident or even be murdered. But it's still a little bit more than you being struck by lightning. Okay, so it's real. I'm not going to tell you, and I have seen it. Okay, but I'm going to tell you your chance of fracturing, if you're in a high risk category, is a lot more than your chances of getting these bad side effects. Okay, almost done. Hang on with me, guys. Okay, denosumab. There's two of them. One's called Prolia, one's called Xgeva. The only difference is 60 milligrams and 120 milligrams. Okay, this is another anti-resorptive, meaning it stops those osteoclasts from working. Okay, we use the Prolia when we're treating osteoporosis. That's one injection, sub-Q, regular injection, twice a year. Xgeva we use sometimes as part of chemotherapy for lots of different cancers with metastases. And this can also be used to treat hypercalcemia. We give Xgeva, if needed, as often as 120 milligrams every month. So the way this works, remember, here are those osteoblasts, the building cells of our bones. They release this thing called rank. Well, what Prolia and Xgeva does is it takes that rank out of the system because we don't want to stimulate osteoclasts. So if we're not stimulating the osteoclasts, you're not going to have those resorption pits. Okay, so breast cancer, AI, aromatase inhibitors, and Prolia and denosumab. As you can see in the placebo group, there was 1 to 2% loss, okay, of bone. But when they were given the denosumab, we actually had an increase in bone density, and that's in women on aromatase inhibitors. So the goods and the bads, okay? It's every 6 months, easy subcutaneous injection. It's not generic yet, so it's more expensive. You have to have your insurance company cover it. The bad about this, in my opinion, is you can't abruptly stop it, okay? So let's say you're done, the AIs, you're off of them or whatever, and you want to stop it. You can't stop it quickly. You have to be weaned off of it, okay? Because you don't want to lose all that new bone you just made. Okay, the side effects, it can cause a rash. I've seen that, not very often. And it's usually in people who already have something, who already have psoriasis, who already have eczema. It can cause bone pain. It's a potent acting directly on the bones. And this medication can also cause the osteonecrosis of the jaw and the atypical femoral fracture. Okay, so in summary, bones are important and fractures are bad. Okay, we're all getting older. Okay, so whether or not we have bone cancer, we're all getting older, and bone health is going to impact all of us at some point. Okay, but those of us with breast cancer have extra things we need to consider because of the medication. When do we go through menopause? Did the chemotherapy cause the menopause? Okay, things can be done. Okay, exercise. Okay, it's very important to exercise. Any kind of exercise. I don't care what you do. Exercise when you're tapping that bone, running or lifting, okay, is going to increase bone density. You need to clean up your alcohol, smoking, that type of thing. And if needed, please be open to talk to your doc about medication. All right, so that's the end of my talk right here. All right, we're going to open it back up and let's see what kind of questions we have.
Okay, thank you so much, Dr. Roy. That was an incredible presentation and you gave a lot of information.
Whoops.
And so I'm going to get right to questions. I've got a number of questions on scans, on DEXA scans.
Okay.
But I want to start first with some earlier questions that came in, and I think you came close on this one. So the first question, how much does osteoporosis inhibit broken hip healing?
Excellent question. I'm gonna break it down. So the question is this: let's say we know you have osteoporosis and you break your hip or you break your wrist, you break a bone. Okay. The vast majority of people will heal. Okay, they really will, because those osteoblasts get stimulated and they're gonna build the bone back up. There are some people where the bone does not heal. The fancy medical term is called non-union. Okay, and there are medications that we can get to, believe it or not, that help the healing. So the medications do not inhibit healing. They actually can help healing. But even if you have osteoporosis, like that third picture on the bottom where your bones look like cheesecloth, you're still going to heal from a fracture.
Thank you. So the next question is, how does prednisone affect a patient's bones?
Prednisone is the best medication and the worst medication in the world. Okay, it's the best medication because there is absolutely no better anti-inflammatory medication. Whether you're using it for lupus, for COPD, for poison ivy, okay, it is a wonderful medication in that respect. The bad thing is prednisone knocks out the osteoblasts, so you're not going to rebuild bone. It makes the osteoclasts even more active. It lowers the vitamin D level. And in a lot of people, it will decrease muscle strength, so they're more likely to fall. So long-term prednisone is a very bad thing for the bones. Sorry.
Okay, thank you. So I'll move on to, again, a couple more medication questions. Does using birth control to stop having a period at a young age affect bone health?
The answer is no, but I mean that in a good way. So if you go on birth control pill, you still have the estrogen. So it's not going to harm the bones. Is it going to make it any better? No. Estrogen is estrogen. You've gotten your peak bone mass at the age of 30. Okay. You're not going to get better than that. Okay. So it does not impact the bones because it will prevent loss, but it's not going to increase bone any better.
Okay. Thank you. Now I'm going to get back. You have given us a lot of information on aromatase inhibitors.
Mm-hmm.
And so the question here is one brand of aromatase inhibitor better than another?
Oh, no.
As it relates to bones?
Well, yes. Let me take that back. The two that affect the bones most are the letrozole and the anastrozole. Okay, so the Arimidex and the letrozole. They're the two that have the most impact on the bones, but they're pretty equal. Neither one is better. Neither one of those is worse.
Okay. Okay. Yes, that was a good one. All right. So, and this is an exercise question. Are resistance bands as effective as lifting weights? And
Or
you
what? I'm sorry. Resistance bands?
resistance bands, you know, those stretchy bands that people use. So are they as effective as lifting weights in terms of building bone mass?
Yes, they absolutely are. What bone wants with any type of exercise, okay, it wants tension. Okay, so whether that tension is you taking a weight and doing curls, you taking a can of soup and doing curls, okay, you doing curls with, you know, the resistance bands, that's what stimulates the bones. Okay, one of my favorite things, and it's really stupid, okay, when people see me do it, my family's used to it by now, but when other people, if I'm waiting in line, oftentimes I'm just going to walk in place, okay, because every time my foot hits, I'm putting stress on that bone to get those osteoblasts to work. Okay. So people think I have ADD and I can't stand still. What it actually is, you know, the microwave, I'm waiting for my lunch to heat up. I'm marching in place. Okay. So anytime you can put a little bit of pressure on the bones are happy. Dancing. Okay. Now, people ask a lot, if you don't mind me keep going here, Eileen. People ask me a lot about swimming, okay, because swimming is an amazing exercise, but there's no direct impact on bones. But the reason swimming is so good is you're using an entirely different set of muscles, and those muscles are going to pull, you know, you're doing the crawl, those muscles are going to pull on the bone there. Okay, so there actually is some impact on bones. But more importantly, the reason I like swimming is going to strengthen the muscles. And guess what? You're going to be less likely to fall. If you don't fall, you're not going to fracture. So you need to think about the whole picture. That's why there's no such thing as a bad exercise.
So I'm going to go back to another exercise question. How much does walking with weights help?
Well, it helps. It helps. It's funny, and I'm not making this number up. Honest, this is the number that's in the literature. The cutoff in a woman, I don't know the man's cutoff, sorry. The cutoff in the woman is 127 pounds. That's where the that's where the risk comes in. So if you weigh more than 127 pounds, adding extra weight's not going to make a difference. You weigh less than 127 pounds, adding extra weights will indeed positively affect the bones. I use that as my excuse not to have extra weight when I go for a walk.
Okay, then because they wanted to know a little bit more about the weight, so that actually was a good way to look at it. So this question, please talk more about specific diet exercise helps. I've lost 5%. I think that's 5% of bone mass
density, yeah,
possibly, and she's 50 years old.
Okay. All right. So what you want to do, part of the endocrine training, okay, is nutrition. Okay. And we are taught there's no such thing as a bad food. Okay. It's the amounts you do. Okay. You can have a glass of wine. You cannot have 3. Okay. You can't, you know, if you're going to make a choice, you know, if you can, throw salmon in there rather than always eating whitefish. Okay, fish is good. Okay, it all comes down to just those healthy things you learned back in health class in 2nd grade. Okay, that there really isn't a bad food. It's just don't overdo the fats. Okay, make sure you get enough calcium. Okay, make sure you get enough protein. Bones need protein. Okay, so there is no special diet. There are some people who talk about food acidity, okay, meaning the more acid the food, the worse it is for your bones. And that's true, except that when most people eat, they're eating a mixed meal, okay? You're having, you know, you're going to have a sandwich, which means you're going to have your grains with a piece of lettuce. You're going to get a little bit of vegetable, and you're going to have the tuna fish in the middle, okay? So nothing really is that important except just eating healthy.
Okay, thank you. So now I'd like to get to some of the questions. So a few on scans.
Okay.
And so I'm going to start with the earlier question. On Xgeva for 3 months before metastatic breast cancer, I got a DEXA scan yearly as part of my osteoporosis treatment.
Good.
Prolia was the drug that she was on. Now my oncologist sees no need for the scans. I worry that I'm missing an important test.
Yes, but no. Okay. And what I mean by that, if the Xgeva / Prolia is going to continue, okay, then honest to goodness, it works. There is no need for the scans. But I want to play devil's advocate for 2 reasons. One, more than 2 reasons. 1, I'm a woman. 2, I love numbers. I love data. Okay. And 3, I want a yearly bone density anyway. Okay. Just because I need to track that personally for myself. So, you know, I understand where the oncologist is coming from. It works. Okay. But on the other hand, it's nice to be reassured. It's not an expensive test. And like I said, there's very little radiation involved. I think breast cancer women on active therapy need to be treated. Once you're years out from your therapy, every other year is fine.
Okay.
But that's just my opinion.
Understood. But that's good information that she can take back to her physician. Now I want to talk about the technology between institutions. So why are DEXA scan reports not comparable between different machines? I had a baseline at another hospital, which was in this case, Mass General.
Okay.
And okay, the other in New Hampshire were removed. And now we're in Albany. I'm dealing with the second. So she has a second breast cancer diagnosis. The radiologist is not interested in comparing an earlier scan because of this.
Excellent question. Okay, real quick. I'll be real quick. There's actually, in the United States, there's 3 different companies that make bone densities. Okay, Hologic, Lunar, and Norland. Okay, but the only 2 we really see in the Northeast are the Hologic and the Lunar. And the reason they cannot be compared is they actually use 2 different sources of radiation. All right, so it's like they're both fruits. One's an apple, one's an orange, but they're different enough that, and I can't remember, I think Mass Gen uses the Hologic. Okay, and around here you may be having a Lunar. So it's strictly, they really cannot be compared. So you need a new baseline here to follow that on that same machine.
Okay, that is a really great answer, and I did not realize that myself. Okay, so now the next question again. My doctor will not order an annual bone density even when I offered to pay out of pocket. Are there studies I can reference to inform them that this would be good for me based on my history? My last DEXA scan indicated that I do have osteoporosis, and we are watching and waiting to determine if and what medications are needed.
Well, with the diagnosis of osteoporosis, you know, medications do need to be considered. Okay. Most of there's all the studies out there, the fancy double-blind placebo-controlled drug studies, okay, did bone densities yearly. Okay. But that's because it was what we call an investigational protocol. Okay. The problem is what you're bumping up against is all the major societies. Okay. American Menopause Association, mine, Endocrine Society, you know, all the ACOG, American College of Obstetrics and Gynecology, all of them are saying that it's an every other year. Okay, so you may have a very hard time fighting that one.
Okay, all right, good. Interesting. So how often should a postmenopausal breast cancer survivor have the DEXA scan? Is that the every other year as well?
That's the every other year as well.
Okay, all right. Now we have another medication piece. I'm taking an injection of Neulasta as part of my chemo protocol to make my bone marrow generate more white blood cells. What are the bone health risks of the Neulasta product?
What a great question. What a really, really, really good question. And I don't have a good concrete answer for you. Okay, what we know, that was a truly insightful question, because what we know is anytime the bone marrow is impacted, Okay, so inside the bones, it's impacted. It literally impacts the bones as well. All right, where most of the data comes from, and this isn't what you have, but where most of the data comes from is multiple myeloma, which, as everyone knows, is a cancer of, within the bone marrow. Okay, and that absolutely thins the bones because they're taking all the nutrients from it. What you're on right now is, like you just said, it's a colony growth stimulating factor. It's just trying to bring the white blood cell line back. So right now, it's not on our radar screen as one of the bad medications. Okay, but in the back of my mind, I'm always like, okay, we're stimulating bone marrow to get those white blood cells. Are we possibly taking nutrients from the bone? It's not enough to worry about, but man, was that a great question.
Thank you. Is a bone density scan recommended after chemotherapy treatment, specifically if after fertility blood work shows that there's a loss of bone mineral density?
Read me that one again, sorry.
Is a bone density scan recommended after chemo? So that's the start of the question. Then specifically, if after fertility blood work shows that there's a loss in bone mineral density?
Absolutely.
Okay.
Okay, for the two reasons. One, we're talking chemotherapy here. Okay. And two, if on the blood test, I think what you're referring to is that the estrogen levels have fallen so much, okay, that I would absolutely want a bone density.
Okay. Are you more likely to break a bone if your cancer has spread into your bone?
It's a funny question, but it depends on where it has spread. Okay, so for instance, if it has spread anywhere in the hips, so from the middle of the thigh up, okay, yes, because we're walking and it's weight bearing, you twist wrong, you turn wrong, okay, a lot of times we're going to do, this sounds weird because here I said radiation can harm the bones, but radiation can also help get rid of the metastases and make that bone thicker in that one particular area. Okay, so a lot of times in the hips, yes, we do it. Okay, from a fracture point of view, okay, not so much in the upper arms, but a lot of times radiation therapy is used just because of the pain. And the other place that we do worry about, obviously, is the spine, because we're all weight bearing on our spine at all times. Okay, so yeah.
Okay, thank you. Now one more question on DEXA scan. What about other tests than the DEXA, such as an NTX, which is a blood test?
Ooh, great question. Okay, so real quick.
We've got a great audience,
This is so much fun. Okay, so what this question is referring to is bone density here I just told you, is how much calcium, how much mineral is in the bone. What this NTX, CTX, P1NP, okay, they're all referred to as bone turnover markers that we measure in the blood. Okay, so when bone breaks down, collagen is the protein in the bone. Okay, and when those osteoclast Pac-Man come and resorb the bone and break the bones down, we're going to be releasing a little teeny bit of the bone into the bloodstream. That's what we're measuring with these bone turnover markers. So an NTX, a CTX, if it is high, okay, and they all have to be done fasting. If it is high, it tells me, oh yeah, those bones are rapidly breaking down, and I'm going to see continued loss on bone density. So the NTXs help us decide. They're not necessary, okay, but I use them quite a bit to help me decide, okay, it's time, let's get you going on the medications. Or, okay, you're starting to lose bone, but look at this NTX is low. You're not in a quote unquote high bone turnover state. Let's buy another year. So by themselves, they won't tell us if you need therapy, but with the bone density, they're an excellent tool.
Okay, so time check. I've got about 5 more questions. Can you stay with us, Dr. Roy, to answer a few more questions?
Absolutely. All right. I'm sorry. I told you I was going to talk long. I'm sorry.
You have given us an enormous amount of information, but it is also prompting some additional questions that are coming in. And so I want to get to as much of that as we can, being respectful of time. And so if people do need to sign off due to other commitments, feel free to take control of your time here. And
yes,
so, but I
want to go make a snowman. Go ahead.
Oh, we'll save that for later. All right, so next question. There are several kinds of calcium and vitamin D supplements on the market. And so obviously supplements are the secondary if we can use our nutrition
Thank you.
first. But would you want to weigh in on any guidance
Yes.
for selecting?
Okay. The way I divide calcium in my brain is calcium carbonate, calcium citrate, and other calciums. Okay. Calcium carbonate is like Tums. Okay. Calcium carbonate, okay, needs acid in the stomach for the calcium to break off from the carbonate so we can have the calcium. Okay. So calcium carbonate is the cheapest. They're also the biggest, and they really should be taken with food. Okay. Calcium citrate, on the other hand, because the citrate part is already acid, as soon as it hits the stomach, it automatically, the calcium breaks off from the citrate. Okay, so the breaking apart you can take with food, without food. Okay, the problem with the calcium citrate is you can't get as much calcium in a single tablet, so you end up taking more. And then the other, so there's this great thing, I'm old and my wonderful mentor taught me this, it's called the vinegar test. Okay, find some clear vinegar. Okay, put that much in it. Drop your calcium pill in there. Give it a little stir, walk away. Come back in 30 minutes. If that calcium tablet has not dissolved, it's not dissolving in you. Okay, and you don't want to get it. So sometimes the more expensive fancy calciums, you put them in the vinegar, it doesn't dissolve. You need to go back to something else.
Can you weigh in on vitamin D as well?
Okay, vitamin D, again, I think this is my bias because, you know, I've lived in New England most of my life and I'm so fair-skinned. I think everybody should be on vitamin D. Okay. Having said that, there really are good studies that if you live Atlanta or south, you're going to get enough sun. Most people down there don't need to be on supplements, but going on 1,000 units a day, okay, is certainly not going to harm. It is certainly not going to be too much. Okay, so that's the minimum I like seeing people on, is 1,000. In some people, especially if they're actively losing bone and I'm going to be treating them with osteoporosis medications, I'm going to measure the vitamin D in the blood and put them on more. But shoot for 1,000 from the get-go.
Okay. Okay, thank you. So let's get back to diet and exercise just a little bit. So you talked earlier about walking and we talked about weights. What about using a weighted vest? This is a question about using a vest.
Well, it's a weighted vest will be good because it's going to put more, it's going to put a bigger impact on the bone every time, you know, you do an exercise and that type of thing. Okay. So again, walking itself, if you're 127 or above, you know, that's not going to help per se. But if you're going to be doing some other exercises, you know, upper body exercises, then a weight vest may be helpful. But just be careful because your body's not used to carrying that extra weight. And you're going to be a little bit more apt to strain the muscles, not the bones, but the muscles, because your body isn't used to this 10 extra pounds.
So that's good. The next question here comes through, can you reverse osteoporosis? So going back to the T-score that we were talking about, once you have hit that osteoporosis threshold, will some of these lifestyle changes, can they effectively bring you back into a higher T-score?
Yes, but okay, what do I mean by that? Is we know if in some people do absolutely increasing the weight bearing, the I don't want to say crunching because don't crunch, but the stress on the bone exercises in early postmenopausal women, we have seen them bring the bone density up. Okay. On the other hand, if we're talking about a medication-induced osteopenia or osteoporosis, like with the aromatase inhibitors, okay, you're not going to be able to you'll be able to stop the loss, but you're not going to be able to bring it back. Okay.
How does the risk of a femur fracture increase with the duration of an Exiva treatment? I'm curious, since many women are surviving longer and potentially on the medication for a longer period.
Exactly. And that's where a lot of stuff is being done, because what we know that those two bad side effects, the atypical femur fracture and the osteonecrosis of the jaw are associated with cumulative doses. So meaning how much for how long. Okay. And we definitely know once you get a lot more, okay, then indeed you're going to be at higher risk. Okay. And lots of studies are going on that, because the good news is we are living longer. Okay. But then, you know, and that's the whole thing of it. Used to be AIs, aromatase inhibitors were only going to be 5 years. Well, now, oh, there's the cat. Sorry. Now, so now that we're doing, you know, aromatase inhibitors 10 years forever, okay, it's going to impact. So that's going to be changing over the next couple of years. I don't have a better answer right now.
Okay, thank you. No mention of Aromadex pills taken after radiation treatment for breast cancer. Is this not a regular standard treatment as well?
It is. And the Arimidex is an aromatase inhibitor. So oftentimes you'll get the radiation therapy first and then get put on it. Okay. And so then that's when you're going to start your active bone loss, is when you go on to the Arimidex.
Okay. And so let's just change another question here. What are your thoughts on collagen supplements?
Collagen supplements might help the joints, okay, but they're not going to help the bone. Okay, even though here I just said collagen is the bone protein, okay, it's very difficult. The collagen that we need in our bones is made by our body. It's not something that we can take. On the other hand, collagen has been shown to, you know, help keep joint mobility. So it's more joint than bone. So I don't have my people taking collagen supplements.
Okay. Let's see, at what point, I have a DEXA every year of continued loss, should medications be considered? I am still in active treatment, and despite walking and calcium and vitamin D supplements, I continue to lose bone density, although it is normal for my age. Is the significant loss from previous scans, should I be considering medication?
I don't care if it's normal for your age. How is it compared to that 30-year-old? Okay, because we're going to start therapy in you and me at a better bone density, because we're going to stay on the AIs and it's going to go down. Okay, so again, if you're getting close to the minus 2.0 T-score, that's when we're going to think about treating you. So if you're still up at minus 1.2 and then you become a minus 1.4, you know, you still got a ways, so you're okay. But when you start getting close to that minus 2, you need to think about it.
Okay. This is a person who started to do more exercise, and she's getting creaking in her knees. And so
right.
Do you recommend any wraps that can be used to lessen the impact on the bones? She's concerned about the creaking.
Okay. All right. So when we talk about creaking and stuff like that, we are talking about joint space. We're talking about osteoarthritis, not osteoporosis. Okay. So, you know, that's where you need to do things for joint health. Okay. So whether it's something like a glucosamine, okay, whether it's going to be something like warm wraps, because remember, anytime you use warm, it's going to pull the blood there, which will help bring down the inflammation. Okay. So it's just, unfortunately, it's arthritis. So whatever, you know, if you need a low dose Motrin, you know, whatever you need is what you got to use.
Okay. I'm going to take just a couple more questions here.
Okay.
So what is the desired blood level of vitamin D? Is there a target?
There is a target. Okay. And not everybody agrees on the target. Okay. So I'm going to give you my opinion. Okay. Normal in the real world, okay, is considered greater than 20 nanograms per deciliter. You don't have to remember that part. Greater than 20. Okay. And I'll agree that's normal. However, like I told you when I started, my favorite topic is bones. Okay. So I like all my people to be greater than 30. Okay. Upper limits of normal, it says is 50, but it is safe up to a level of 100. Okay. So I will agree, general population, greater than 20. Bone world, which most of us on this call are in, I want you greater than 30.
Okay. Understood. And then are there any studies that say Arimidex might affect bone loss? Arimidex, excuse me, I pronounced it wrong.
Yeah, Arimidex is one of the aromatase inhibitors, okay, and it's one of the two, okay, not Aromacin, Arimidex, okay, that is one of the ones that is going to cause the, 1 to 2% loss continuously. It's not going to even off. So yeah, there are a lot of studies that show that.
All right. One more follow-up question about the Exiva doses. Let's see, follow-up. What is the longest interval between Exiva doses? Often given every 3 months, wondering if it could increase interval to decrease side effects.
Okay, so from a bone point of view, not a cancer point of view, from a bone point of view, you cannot go past 6 months. Okay, because we know if you miss it at the 6 months, then you're going to start to lose bone again very rapidly.
Okay.
Okay, from a cancer point of view, it's really interesting. One of the differences between studies in the bone world and the cancer world, okay, is in the bone world, we try to space things apart, and if need to, we bring them closer together. In the cancer world, because we're dealing with cancer, they start close together and start spreading them apart. For instance, the other medication that we use sometimes in quite a bit actually in metastatic diseases is Zometa or zoledronic acid. Okay. In my world, okay, I would use the osteoporosis world. It's a once a year injection. Okay. In the cancer world, when I started and this medication first came out, okay, back in the late 90s, okay, it started as a once a month injection. Then finally they realized, okay, let's go to every 3 months. So then there's studies now that's saying every 6 months. Because what the thing is that Xgeva being so new is it started monthly, and now we're getting the 3-month data. I'm not familiar of 6-month data yet from a cancer point of view. Bone, absolutely. Cancer, I don't think that data's out there yet.
Different situations. Yes, understood. Okay. So that wraps up our questions. I think we had 26 questions. So you just shot right through that. And thank you for all of you brought up things. Who would ever thought we needed to do a vinegar test, right?
Exactly.
So, and now we know about the vinegar test. So what I'd like to do is say thank you for sharing just a wealth of information. And now I'd like to invite Melanie McCulley, our Support Services Program Manager, to say a few words, wrap us up.
Thank you so much, Eileen. Dr. Roy, you are awesome. I mean, I love someone who's a total geeks out on a subject that we're passionate about as well. We cannot thank you enough. This is the
my pleasure.
#1 topics that we get requested. So thank you so very much for that. And again, I always say we have one of the most intelligent, sophisticated audiences with their, they're really very insightful. So thank you, everybody. So this was the 4th of our 6-part Women's Health Conference. We have 2 more sessions left in the new year. Believe it or not, the new year is finally arriving. We all have great anticipation. So we have Dr. Jennifer Bremser on January 12th. She is going to be speaking about breast cancer and cognitive health. And then we wrap up the entire series with Dr. Khan of St. Peter's Hospital on January 26th. And that will be about metastatic and complex breast cancer diagnoses. So there's still time to sign up for those. If you haven't already, go to Eventbrite, register, and we will make sure we get the link to you for that. Our services continue. I know we're mostly virtual at this point. We do have boutique appointments for both our wig and our prosthesis product, or I'm sorry, mastectomy product boutiques. Those are by appointment with appropriate safety screening and protocol. Our support services and support groups continue by phone and virtually. And we are there if you need us. So please don't hesitate to reach out. I think all of you have my email, especially because I sent you the link. So you have that. You can reach out to me at any time and I will get back with you. And until then, we thank you so much for your support for these programs. Please fill out the evaluation. Those evaluations are really important to us. We take your information very seriously. So I will be sending that later today. It's a very brief evaluation. If you could just fill that out, we so appreciate it. Please take care of yourselves. Please continue to be compassionate with yourselves, find ways to enjoy the holidays, and we wish you a happy Hanukkah, a Merry Christmas, Happy Kwanzaa, Las Posadas, and Happy New Year. Take care. Thank you.
Thank you. Bye-bye.